Good evening. I'm happy to be here. I think we have an interesting program in front of us. And I'm going to give an introduction to the topic. Here is my potential conflict of interest. I'm going to talk about risk factors. Risk factors has different meanings, and it can be very confusing when people are not defining what they are talking about. And I will try to go through some of the different meanings of the term risk factors. Risk factors can be a maker of the disease, indicating a causal relationship to the disease. And of course, no one today will dispute that cholesterol is a maker of atherosclerosis. It has been shown many years ago, first time by Anichkov, nearly 100 years ago, that giving cholesterol to animals induced atherosclerosis, and we have many other evidence indicating that cholesterol is a maker of the disease. There is a causal relationship between high cholesterol level and atherosclerosis. Then we have other risk factors that are not necessarily makers of the disease, but markers of the disease. There is a relationship, an association between the risk factors and the disease, and there's many of them. In 1981 there was 246, and today there's many more. And they are just statistically associated with coronary heart disease, though cause and effect relationship has not been demonstrated for all of them. In fact, only very few of them are causally related to atherosclerosis. One of these risk factors that is statistically associated with the disease is C-reactive protein. And it has been shown consistently in many cohort studies that a high level of CRP is associated with an increased risk of coronary heart disease. And the association is as strong as it is for low-density lipoprotein, high-density lipoprotein, high blood pressure, and smoking. But again, it's a statistical association. And it has been shown here in the review article in many studies, in nearly all studies that has studied the association between CRP and coronary heart disease has shown this association. Of course, the question is whether this association also indicates a causal relationship, so that a high CRP level causes atherosclerosis. And in fact, this question was, I think, answered just a week ago by this publication from Copenhagen, from Denmark, where I'm coming from, published in New England Journal of Medicine from the Copenhagen Heart Study. Genetically elevated C-reactive protein and ischemic heart disease. And in fact, the question was asked whether this association also, in fact, was indicated a causal relationship. So they tested whether high CRP level was causally related to coronary heart disease, and they did it by identifying genetic markers, polymorphisms in the gene for CRP, to see if a genetically elevated CRP level was also associated with an increased risk of ischemic heart disease. And it is concluding here, I don't think you can read it, so I will read it for you. The conclusion is that polymorphism that is genetically determined high CRP level are not in themselves associated with an increased risk of ischemic heart disease. So the genotype here in this figure, the genotype was associated with a high CRP level, and it was associated with a predicted increased risk if CRP was high for ischemic heart disease, but there was not observed any increased risk. So genetically elevated CRP level was not associated with an increased risk of coronary heart disease. It was associated with this editorial in New England Journal of Medicine, where they discussed the difference between observational studies where you have different confounders and you have reverse causation, and it's very difficult to in fact adjust for all these confounders, and what you have here, what you call Mendelian randomization. You are born with a high CRP level. You have it not yourself determined to have a high CRP level. You are born with it. So it's a kind of randomization called Mendelian randomization. And the conclusion in this editorial is that what are the implications of the finding? First, CRP is not causally involved in the pathogenesis of atherosclerosis. It is no maker of atherosclerosis. But yes, CRP is indeed a marker of the disease. High CRP level is associated with an increased risk. Then the question is, of course, whether it is a useful predictor of the disease, the utility of measuring CRP level to find people that need treatment. And maybe we'll get the answer tomorrow. Is it tomorrow where the Jupiter trial will be presented during the hotline session? So it was a maker of the disease, cholesterol. It was a marker of the disease, C-reactive protein. Now we are coming to predictors of the disease, whether these risk factors, markers of the disease, also predict people that are at high risk of having a heart attack. And a very important component of a predictor is whether it's able to distinguish between those that would develop the disease and those that will not develop the disease. Okay, here we have the Framingham data. They have already published the limitations of LDL cholesterol as a predictor. In fact, there is 80% overlap between those that in cholesterol level, between those that develop ischemic heart disease and those that do not develop ischemic heart disease. So, in fact, 80% of the patient, it is not very useful to measure cholesterol level. It has been confirmed in the BUPA study from UK in 22,000 men followed for more than 10 years. Those that developed ischemic heart disease and those that did not develop ischemic heart disease, there was a huge overlap. 80% of them had similar cholesterol level. The same was found for ApoB level in the blood. In the same study, the same was found for blood pressure in the blood. You can see huge overlap. Measuring the blood pressure is not a good predictor to find those that will develop the disease. In fact, you could as well flip the coin for most of them. Only those that has very high level is it useful, and only for those that all have a very low level it is useful to say you are at low risk or you are at high risk. For the great majority it's not very useful. And it was a background for the introduction of the pulley-pill principle, because as Walt and Law said here in 2003 in the British Medical Journal, if you cannot find the people that need treatment, then we need to treat them all. And after year 55, the risk is very high, so they suggested that all about year 55 should be treated with a statin, with aspirin. They also had some lower the blood pressure, and they also suggested to lower the homocysteine level, because we cannot find the people who need treatment. Then you can say, well, it's if you measure only a single risk factor, cholesterol level, blood pressure. If we measure all of them and make a global score, what we're using today, a Framingham score, maybe it will be better to find those who need treatment. They did that in Britain in the Northwich Park Heart Study. It was published just a few months ago during the European Association of Atherosclerosis in Istanbul, and we have the data here. It's a global score that include all the classical risk factors. And again, you can see there is huge overlap between those that have a high score and a high risk and those that have a low score and did not develop the ischemic heart disease. And if they set a reasonable limit for which the amount of people that don't develop ischemic heart disease that we will give the treatment, it is a 5% false positive rate. Then they found, in fact, that only we will prevent 14% of all ischemic heart disease. So they conclude most events occur in men with an average risk score. 86% of the 10 years events was not predicted by the coronary risk factor score as a global score. So they suggested, can we improve on this with new risk factors or genotypes? A few weeks ago, also from the Northwood Park Heart Study, they published the result for CRP. And you can see here again, cases is the patient that developed ischemic heart disease, and controls, those that did not develop ischemic heart disease, followed 10 years follow-up, huge overlap. So in fact, you could nearly as well flip the coin. And they went through 27 prospective studies where they have assessed the predictive power of CRP. You got the same results. And the conclusion was CRP provided statistically significant but quantitatively small improvement in risk assessment, because there was wide overlap of CRP value. And the large proportion of events occurred among the many individuals with near average level of CRP. There is other measures of the ability of a predictor, calibration, reclassification, and so on. And it was discussed recently in this paper by Cook, where the limitation of the ROC curve or the C statistics was highlighted, and they measured what should be evaluated when you want to assess the ability of a marker to predict risk: global model fit, calibration, discrimination, reclassification, and maybe the most clinically important, will it change the treatment? If it will not change the treatment, there's no reason to reclassify people. So I have tried to go through some of the larger prospective trials to see what kind of misclassification do we see in these trials. And it is well known, also mentioned in the recent guideline from Europe published last year, the European guideline, that in fact most deaths in the community come from those with lower level of risk. It's a Rose paradox. So most events come from those that are not identified. They are misclassified, not identified as being at high risk and not offered preventive treatment. And many of you know this study from COSA that also showed that many of people admitted to the hospital with their first myocardial infarction in young age, they come into the hospital without any treatment. They were not identified. In fact, when they went through the records, they found that only 25 of these people admitted with their first myocardial infarction fulfilled the criteria to receive pharmacological therapy according to current guidelines. Last year in JAMA, Bridger proposed a new risk prediction algorithm. He called it the Renault scores, and it was better than the current score. All measures of fit, discrimination, and calibration were improved. Well, it was improved, but when you compare something with another thing that is not good, that maybe you can improve it, but it does not indicate that you have a good score for risk prediction. So I went through all these data. It's very difficult to find because they are not given as these numbers in the paper. But it's from the Women Health Study, and they were followed for clinical event. And Bridger, in the validation cohort, he studied 7,911 female. 6,944 were at very low risk according to the best model that included CRP. And in this large group of female, 99 events occurred. In contrast, only 59 female were at high risk, more than 20% risk for having a heart attack or an event in the next 10 years. It was a global event score that included many different ischemic events, also stroke. And in this 59, 18 events occurred. But as you can see again, most heart attacks with the best model occurred in people misclassified as low risk, and most people at high risk was also misclassified because they did not develop any events. So if you decide to give people with high risk treatment to prevent heart attack, you will prevent 18 out of 199 events. You will prevent 9% of all events. And it's also the background for this double approach. You say we need a population-based approach and we need a high-risk-based approach. The high-risk-based approach, that is the current guidelines today for cardiologists, will prevent only very few of the events in the community. It was female. What about male? We have the result from Northwich Park Heart Study. It's male. And it was also published recently. 2,412 male, 2,328 were considered at low risk, risk less than 15% for having a coronary event in the next 10 years. And in this population, 140 events occurred. And only 84 were considered to be at high risk and 90 events occurred. Again, if you consider to treat only those with high risk, you will prevent 19 out of a total 149 events, it's 12% of the event. So the approach today, by treating high risk, you will only prevent a very limited number of events, because we cannot find the people who are at high risk. So the current approach, by using risk factors, we know risk factors, we know pathogenetic factors, but these factors are not good to risk stratify and identify those that are at high risk and need treatment. Why? Probably because we miss something. It's a susceptibility for the disease. Some people are susceptible for risk factors and develop the disease, even if risk factor level is low. Others are very resistant to risk factor, and they can resist risk factor without developing the disease. So if we go back again to these men in the Northwich Park Heart Study, you can say, exemplified by these two persons, Jim Fix, that was a marathon runner that died in a young age of a heart attack. He belonged to the huge population, probably with a low risk factor level, that although the risk factor level is low, they develop heart attack because they are susceptible for the disease. And Winston Churchill belonged to the other end of the spectrum. He probably had a lot of risk factor, but he did not develop the disease because he was not susceptible for the disease. How can we detect or assess susceptibility to the disease?